This is a chest x-ray on a 38 years old asymptomatic female patient. This is actually a neat case that has a few teaching points that are both good for seniors and juniors. The abnormal finding here is a difficult catch, but if you compare both lungs, you'll see it. As a general rule, in a well-performed chest x-ray, the density on each side of the midline should be equal. Applying this rule, you notice that this is not the case. There is this faint rounded opacity in the left mid-lung. The differential diagnosis for such a finding is wide and depends on whether the patient presents in an acute or chronic fashion. For example, if the patient presents with fever, leukocytosis, you'd suspect that this is a pneumonia that needs treatment, and you could do a follow-up to make sure it's resolving. What we need to remember here is that an opacity seen in one view may not be within the lung. The possibilities are even more than that. This abnormality may be a parenchymal lesion, but it could also be a pleural, subpleural, or chest wall finding. And here's the CT scan on the same patient with intravenous contrast. This is the appearance in lung window. So after all, the lesion is not in the parenchyma, it's outside of the parenchyma and based on the pleura. It has a density that is of soft tissue, and when measuring this, the density is about 50 to 60 Hounsfield units. The abnormality is extremely well defined and does not invade the chest wall and is not associated with adjacent bone changes. It also has this unique appearance of an elongated configuration in between the 7th and 8th rib. So this is a lesion that's located underneath the 7th rib in the intercostal space. And here's another important finding for seniors. We talked about the subpleural fat. This is the subpleural fat surrounding the lesion here. See how the subpleural fat is creeping along the edge of the lesion, suggesting that this lesion arises from underneath the pleura. Of course, this is not a definite finding of a subpleural lesion. This could still be a lesion that's arising from the pleura itself. More information on this lesion. The abnormality is stable since 2007. Given that this lesion is stable, it's reassuring for a benign nature. It is not associated with lung changes, and it's not intraparenchymal. It's either pleural or subpleural. It has soft tissue density and is well defined without aggressive or invasive features. There is a suggestion of elevation of the subpleural fat, meaning that this could be subpleural in nature. And it has this oblong appearance in the intercostal space. All of these features are suggestive of a neurogenic tumor. More specifically, this is likely a schwannoma of the intercostal nerve from the bronchovascular bundle that passes in the intercostal space. Another reasonable differential diagnosis would be a fibrous tumor of the pleura. More concerning neoplastic malignancies would not be considered given the stability and the lack of invasive features. So what have we learned today? First, look carefully for opacities, and the trick is to compare both lungs for symmetry. The rule is the density on each side of the midline should be equal. The other teaching point is that a density that is seen on one projection may be in the lung or outside of the lung. By outside, we mean skin, chest wall, subpleural space, or pleura. Finally, CT is a good way to go to evaluate such an abnormality. Assess for the density of the lesion, the well definition, lack of aggressive features, and the location. And remember, one of the differential diagnoses of an intercostal space lesion is a schwannoma of the intercostal nerve. A subtle finding to look for is the status of the subpleural fat. Is the lesion arising from there and surrounded by it? If this finding is seen, the lesion could be subpleural rather than pleural in location. Thanks for watching. More cases later this week. And by the way, if you haven't done yet, I uploaded a free lecture on a trick that helps you detect collapse on chest radiographs. Go to this web page, search under Radiology Bits, and you'll find the lecture. In the price section, place a 0, and that removes the paying option, and you could just put your email and receive the lecture. Of course, your feedback and comments would be very important to me, and see you later. This is an abdominal CT scan on an 85-year-old male patient with multiple comorbidities. The reason I'm showing this case is for one main teaching point, but I'll show you a few findings for the sake of orientation. Here we catch part of the lower chest where we have what seems like cardiac enlargement. The patient has mitral annular calcifications. There are bilateral small pleural effusions, and the patient has dependent lung changes as well. Extensive vascular atherosclerotic calcifications are noted, and there is this large amount of free air within the abdomen. The free air or pneumoperitoneum was not surprising and was known it was secondary to aggressive insertion of a gastrostomy tube. Here is the pneumoperitoneum. This is the gastric wall with a gastric bubble, and this is the gastrostomy tube piercing the wall. There are gallbladder stones, as you see here, and here as well. Here in the lateral chest wall, you see part of a chest tube which is not fully visualized, and some adjacent subcutaneous emphysema. This subcutaneous emphysema, which could be better visualized using lung windows, is expected post chest tube insertion. Both kidneys are atrophic, which is also not surprising since the patient has chronic renal disease. So I showed you several findings, but I didn't show you the finding that pertains to our teaching point. I'll give you another chance. Now back to the upper image where we see the lower chest. And the unusual finding that we have to follow is this dense structure here. So this is a tubular structure that runs within the opacified right lower lobe, crosses the subpleural space that we talked about yesterday, runs lower down within the subpleural space, and dissecting into the upper abdominal wall in this region. On bone window, you'll notice that this high density structure contains these dark areas which represent air containing side holes. And now you could see that this is actually a tube with a radiopaque marker. The important question is, what is this tube? There is no normal tube that runs in such course. To answer this question, I'm going to show you the chest CT that was done after the abdominal CT scan. So let's follow this tube backwards. It still runs within the right lower lobe, that's abnormal. You see the tube within the lumen of the right main stem bronchus and within the trachea. And here's an image higher up. This is the air-filled tracheal lumen. This is an endotracheal tube, and this is our abnormal tube running beside it. This tube is actually a nasogastric tube that was intended for esophageal intubation. The esophagus is here. And now the story is clear. Instead of going into the esophagus, there was intubation of the airway. And this misplaced nasogastric tube runs in the trachea, goes all the way down into the right main stem bronchus here, continues within the bronchus intermedius and into the right lower lobe, then into segmental and subsegmental branches of the right lower lobe. before piercing the pleura and running within the subpleural fat-containing space, and finally dissecting into the right upper chest wall adjacent to the ribs. And here's a coronal image showing the nasogastric tube within the trachea, going into the right midsection bronchus and then into the right lower lobe. The main finding I wanted to show you here is misplacement of a nasogastric tube into the airways. The reason I started by showing you all the other unrelated yet important findings is that this is what you're going to face in real life. If you don't have an organized and systemic approach, you'd be distracted by all the other findings. Part of your evaluation in reading any kind of imaging modality, whether it's a chest X-ray or a CT of the abdomen, is to check for tubes and lines. Make sure your tubes and lines have a normal course and a normal termination. So again, remember, always check your tubes and lines for normality of the course and termination. That's it for today's case. Thank you for watching. More cases later this week. Today's case is a quick show and tell case. I want to show two main things. The first thing is seen on this chest radiograph. This is a patient with cardiac disease. You could tell by the presence of this device. Many would call this a pacemaker, but this is actually not. This looks similar to a pacemaker since a pacemaker has this generator device. It has one or more leads and ends with a tip that could terminate in an atrium or a ventricle. The thing that you should not see with a pacemaker is this dense and thicker metallic component here and there. So these two metallic components are called shock coils. If you see this, that means that you're looking at what is called an implantable cardioverter defibrillator, ICD. In general, an ICD is different than a pacemaker. The indications for placing each device is different. The guidelines and indications for placing a pacemaker or an ICD are complex, but we're going to simplify this. As most of you know, the pacemaker is placed for controlling arrhythmias, while the less familiar ICD, which has shock coils, is usually placed to prevent sudden cardiac death. As we mentioned, pacemakers, for the sake of simplicity, are there to control arrhythmias, while ICDs are placed for prophylaxis against sudden cardiac death. The indications are more complex than that. If you see the shock coils that we talked about, that means that this is an ICD. In that case, an ICD could be an isolated ICD or combined with a pacemaker. So when I say it's not a pacemaker, a better way of saying that, it's not your simple or typical pure pacemaker. Again, seeing the shock coils makes it an ICD, which may or may not be combined with a pacemaker. So to simplify, if you see a shock coil, say it's an ICD in your report, but don't mention it's not a pacemaker, because it could be as well. This is the CT on the patient who had substantial ischemic cardiomyopathy and an ejection fraction of less than 20%. In such patient with a very low ejection fraction, there's a higher risk of sudden cardiac death, and that's why the ICD was placed. The other thing I want to show you is on the CT scan here. This is a CT without contrast. Have you noticed anything that's unusual? This is the location of a dilated left ventricle, and this is the location of a right ventricle. Normally, without IV contrast, you cannot differentiate both. However, here you could differentiate by this hypodense line. So let's look at this linear dark structure here. The density of this abnormality is equal to that of fat here and fat here in the subcutaneous region. So this is fat within the myocardium of the septum as well as the myocardium of the cardiac apex. And this is the reason you could partially differentiate the left ventricle from the right ventricle on this non-enhanced CT scan. The most important question to answer here is, why does this patient have fat in the myocardium in this area? The most common reason you'd see myocardial fat deposition is related to a previous myocardial infarction. This happens usually about a year or more from an old myocardial infarction due to fatty metaplasia. Now, clinically speaking, in this case, this was not a very important piece of information because the patient is known to have a remote myocardial infarction there. However, you may be the first one to report an unrecognized old myocardial infarction. This is especially the case in populations with high diabetes, since diabetics may have silent MI, and if that's the case, that's a very important prognostic piece of information. The most common reason to have myocardial fat is an old myocardial infarction. As someone who's reading a CT scan, you may be the first person to report an unrecognized old myocardial infarction. This becomes clinically important, especially in patients who are diabetics who could have silent myocardial infarctions. Thank you for watching. See you with more cases next week.